So today we will be discussing about airway. So maneuvers to open up the airway are head tilt, chin lift and jaw thrust, and then we go ahead with bag and mask ventilation with the help of AMBU. Other is we have a oropharyngeal airway, that's name is Goodell's airway. It helps us to prevent the tongue from falling back and obstructing the airway. It also allows us and helps us to suction of the secretion. It is useful in the unconscious or semi-conscious patient who cannot guard their airway. And it also helps in prevention of aspiration. Then we have supraglottic airway. In supraglottic airway, we have laryngeal mask airway, which is known as LMA. It has an inflatable cuff. There are various types, that is classic LMA, then there is a flexible LMA, then reinforced LMA or intubating LMA that helps in endotracheal tube insertion. Then some are the recent generation, that is second generation supraglottic airways that have a esophageal drain tube. The name of these are Procel and iGel. Then we go ahead with endotracheal intubation. In that we have orotracheal intubation or nasotracheal intubation. For endotracheal intubation, we commonly use rapid sequence intubation, in which we use IV anesthetic. Along with that, we use a rapidly acting muscle relaxant to secure the airway quickly as possible. For intubation, we use either Macintosh laryngoscope or we use fiber optic bronchoscope. It can be helped to definitively secure our airway. Then we have double lumen tubes or endobronchial tubes. These allow deflation or collapse of single lung along with selective ventilation of the other lung. It is useful in thoracic and esophageal surgery. Then we come for airway assessment. For airway assessment, we have mouth opening, which could be 3 to 4 fingers normally. Then thyromental distance, that could be 3 to 4 fingers approximating to 6 to 8 centimeter. Then the neck mobility, the tongue size. Then we have the Malampatti grading, which shows us the mouth opening. It is divided into class 1 to class 4. In class 1, we can see all the parts of the oral cavity, that is soft palate, fauces, uvula, tonsillar, pillars. In class 2, we will see soft palate, fauces and uvula. In class 3, we will only see soft palate and fauces. In class 4, we will be barely able to see the soft palate. Then we come for difficult airway. In difficult airway, we will decide the primary strategy, whether we have to go ahead with awake intubation versus intubation after induction. Then we will go ahead decide whether we will go with non-invasive airway or invasive airway. Then spontaneous ventilation versus mechanical ventilation. When the first attempt of intubation fails, we can go ahead with face mask ventilation. Then we can, if that is adequately getting ventilated, we can go ahead with reattempting intubation. Then we can, if the face mask ventilation is inadequate, then we will go ahead with laryngeal mask airway, and if that is also inadequate, we will go ahead with invasive airway. If LMA is adequate, then we can reattempt intubation. If that fails, we will go ahead with invasive airway, or we can, other option that we can awaken patient and retry after some time. Thank you. See you in next video.